please.
Yes, we're live now.
Right, thank you. Thanks, Leslie. Welcome to everyone, councillors and ladies and gentlemen. Welcome to the Health and Wellbeing Overview and Scrutiny Committee on Tuesday, the 6th of April. First on the agenda, we have apologies for absence, please.
I have no apologies.
And I don't think Chris has any. Great. Minutes of the previous meeting that have all been circulated. From the 2nd of March. Can we take those as read, please? Is that a yes, no, or could show somebody propose the minutes?
I'll propose them, John.
Thank you, Elizabeth. Have we any comments or actions regarding the minutes? I can't see anybody.
Yeah.
I can't see everyone, so Chris or Leslie, if I don't see somebody with a hand up, could you please just inform me? We go on to disclosures of members' interests. Do we have any? Again, I can't see any of that. Thank you. Next to the forward plan. Chris, have we anything in the forward plan?
The forward plan's just the members to note at this stage, Chair.
Thank you for that, Chris. Health and Wellbeing Board, the minutes of that, which was on the 11th of February. I know Councillor Dodds here. Is there anything you want to bring up on that, Councillor Dodds?
No, I mean, it's obviously heavily COVID inspired, as it were. I don't know if anybody's got anything to add. I mean, we have the briefings every fortnight.
Yeah.
I think we're on the way to returning to normal, but we'll have to wait and see for a bit more data to come through. But I think it's good news, isn't it?
We're getting there. Whatever, if we can, any of us can remember what normal is. Thanks for that, Councillor. Is anybody who has any questions on those minutes? Again, I can't see any hands there. Item 6 on the agenda, Northumberland Healthcare NHS Foundation Trust Annual Plan and Quality Account. You all have that in your minutes. And I think we have Mr. Rushmore. Jeremy, I think, is hopefully with us. I can't see anyone yet. Chris, have we somebody to take this plan?
Can't see that Jeremy or anybody else from Northumbria is on the meeting.
I can't see them either, and well, I know we have if there's nobody here, I see we have Pamela Travers, who is taking the next item. If it's agreeable with everybody, we'll go to the CNTW experience of COVID and the future. And I believe we'll have Pamela, who is going to take this presentation. Pamela, are you ready to take your presentation?
Yeah, Chris very kindly has said he'll project it for us.
Yes.
We're all a bit non-technical. I brought along 2 colleagues with me to do the presentation. So firstly, just thank you for inviting us, because I know that CNTW haven't really been regular attenders at the meeting. So we just want to say thank you for inviting us.
Yeah, you're welcome.
I have with me Kath Elliott and Chloe Mann, who will talk through the experience of the teams, what we've delivered as services, what's our future thoughts about work that we need to do, taking it on board what's happened within COVID, and also the 5-year plan for mental health services. We are due to come again. I think it's May that we're due to come back. So if that's okay with you, Chair, that we'd like to bring different members of the team each time, so you can start to meet the team for the North locality for CNTW.
Pamela, I think it will be June. There's not a
June.
meeting in May.
I think
it's on the agenda is May, but it's June is the next meeting. And yes, you're more than welcome to bring any member with you on that.
So today the presentation is about what we've been doing through COVID and, as I said, the future plans. So what I'll do is I'll hand over to Kath and Chloe to start the presentation and talk about the teams that they lead, if that's okay.
Thanks, Pam.
Okay, so my name's Chloe Mann. I'm the Associate Director for our access services in the North locality. So that's our crisis teams, our psychiatric liaison services and our addiction services. Can we move on to the first slide? Is that okay? So I'll go through what each of the teams have been doing throughout the last year and take you through what our experiences have been in terms of the COVID response. So our psychiatric liaison team are based at Cramlington Hospital, NSEC Hospital, and they work out into all of the different base sites across Northumberland, Hexham, Blythe, Berwick, Alnwick Infirmary. So we've continued to provide face-to-face contact throughout the pandemic, 24/7 throughout the Northumberland area. We were asked very early at the beginning of COVID by the Royal College of Psychiatry to provide a separate mental health emergency department. And this was to try and reduce the amount of footfall coming into the acute trusts and to prevent that cross spread of infection where it could be made possible. The team worked really hard and turned this round overnight, and we have a separate department within the main hospital where we can bring our patients who need to be seen that don't require further physical health intervention. And this environment's provided a more safe space and a quieter area for us to conduct our holistic assessment of their needs before leaving the acute trust. In May, which was just 6-7 weeks in, we were then asked to put in an enhanced children young persons pathway. We did this by using our children's crisis team to join the existing team based at NSEC Hospital. And it meant we were able to see people from the age of 0 with no upper age limit, and they could have a timely response within 1 hour to meet any needs they had within the acute setting. We were asked again and very early on into COVID to provide an enhanced pathway for those people that are aged 16 to 25. This age group has been identified as that transition period for young people moving in from children's services into adult services, and can sometimes be really difficult to do a needs-led assessment. So we use the skills of both teams and come together working jointly to do that assessment of those people to make sure they were getting the appropriate treatment that they needed. And then we're currently piloting a 7-day-a-week extended service for our older adults liaison service. Initially, it used to be Monday to Friday, 9 to 5, and sometimes people were having to wait in hospital for a prolonged period of time over the weekend or overnight to wait for a specialist assessment. And we're now able to provide that over the 7 days a week. And we've been looking at the demand and need for that resource and service. And it's proved to be really, really well received and something that we can hopefully continue going forward. Next slide, please. Moving on to our universal crisis team. So the pathways within the universal team are for our older persons, working age adult pathway, and younger persons. And these all sat very separately and varied in what response was able to be provided. So this plan was accelerated and turned into a 24/7 crisis care for our older adults, which previously, again, was only a 9 to 5 service. We're now able to respond to all levels of need, whatever time of the day or night, keeping people at home where possible, or within nursing care if that's their place of residence. And we've had really good response working with the care homes throughout the pandemic. We offer an urgent assessment, which is within 4 hours of referral. We take referrals from all areas, whether that be self-referrals, professional referrals, and we work very closely with carers and family who support people at home. Next slide, please. Our working age adult pathway is probably the longest standing pathway for crisis teams, and the first thing that had been stood up several years ago. We've worked very closely with all services surrounding us, both health and social care, including housing providers and the wider community, to really support people in delivering home-based treatment and preventing unnecessary hospital admission. We know that people recover well and better when they're surrounded by familiar environments and by those who are able to support them at home, rather than disrupting their life by bringing them in and out of hospital. We've worked very collaboratively and directly with Together in a Crisis, and that was launched in lockdown 1, so very early days they came on board, and a lot of people that we work with will have intervention from Together in a Crisis to look at all other aspects of their needs, not just their mental health alone, and it's been a great asset to the team. Next slide, please. And then our younger person's pathway. So we're recognising, as I spoke about in our liaison team, that up to the age of 25, people can present a particular risk, and we know that the pandemic has had a significant impact on young people's mental health. The ability for them not to be at school and having the routine that they would normally have has had an impact on anxiety levels, on people's mood, and by accelerating our plan to provide that 24/7 cover for young people, it's enabled us to work very closely with community teams, again with social work, with schools, and all of our healthcare providers that surround us. The crisis team initially were supporting the liaison development to make that work overnight, and we've now been able to develop and recruit to have that as a separate team, so we're not utilising resources across both areas. And if any young person under the age of 25 has been seen in an acute hospital, the Universal Crisis Team for Young People will do up to 3 follow-ups for that young person at home or at school. And this is to allow a further assessment of their needs and reduce further deterioration, especially for those that have presented for the first time to services. Next slide, please. And the final service that sits within my portfolio is our addiction services. And we know that the impact of COVID has had a massive impact on all service users. Our teams continue to see people face to face throughout the pandemic. We've adapted using technology to deliver virtual groups, which have been absolutely fantastically attended. And it's allowed people that wouldn't normally want to socialise or maybe been anxious about being in a group setting, the ability to engage and to contribute to not only one-to-one sessions, but also to something that's been new for them. We've adapted our approach to the most vulnerable. We provided mobile phones to some service users to ensure that we were able to maintain contact and review how they were, how their mental health, and also that their needs were being met. And the amount of food parcel provision that we've seen has been massively increased, and we're really, really proud to say that we've been able to support people on a daily basis with food parcels to ensure that they're able to get enough nutrition and an adequate diet. It's been a great way to engage people as well, people that may have not wanted to meet with us and didn't want to maybe talk about their mental health or their problems. By introducing a food parcel and other social supporting factors has really helped them to engage with what we would like to do and support them with. Our addiction service is going to be growing. We're reviewing our pathways. We're looking at how we can increase what we provide to those that need our services in Northumberland, particularly in terms of harm reduction and support and advice through that. And those that maybe have come through drug rehabilitation order through our prison services or criminal justice liaison. So really that early intervention to support people with what they need. Next slide, please. I'll hand you over to Kath for the next part.
Hi, good afternoon, everyone. Can you hear me all right? Good, okay. Thanks for having us this afternoon. As Pam said, my name's Kath Elliott. Sorry, could you hear me?
Yes, fine, thanks, Kath.
Yes, okay, sorry. So I'm the Associate Nurse Director for Access and Community Services based in the North locality, but for the purposes of today, I'm going to be talking about our community services in Northumberland. In Northumberland. So we've got a number of teams spread, as you'll know, throughout Northumberland. We've got quite a large geographic footprint to cover. So some services have done something slightly different to others to enable us to continue to provide the care and treatment that we've needed to do. So from the outset of lockdown, there was a national mandate for us to step down all non-essential face-to-face contact, and that was in line with national guidance. And it was a measure that was put in place to support both staff and patients and carers and support their safety. So very quickly we had to look at putting a robust system in place that reviewed which patients required essential face-to-face support, and that was based very much on the risk that we'd already established and assessed with a lot of patients that we work with. So all caseloads were initially reviewed by a clinician who knew the patient. It was based on previous risk assessments and a knowledge of that patient. And if there were any further queries, then a multidisciplinary discussion could be initiated. So essentially patients who were deemed to be higher risk would have a face-to-face, were seen in a face-to-face setting. So for example, patients who required a depot injection or required blood monitoring for other medication would be seen in face-to-face. Other patients who were offered regular non-face-to-face contact would be offered either via telephone or other digital solutions like one consultation. So while we used digital technology and it significantly enhanced our ability to maintain contact with our patients, there were some drawbacks. Assessments that we would ordinarily do on a face-to-face basis they're very much multisensory, in that a clinician would be looking at the person's environment, looking at how a patient presented, so what the physical presentation might be. So for example, weight loss might be a key trigger for some specific patients, and you don't always have the ability to see that using digital technology. I guess the other things that we pick up when we're having face-to-face contact with patients is potential safeguarding issues. And that was particularly relevant when we're thinking about our children's services. So families and carers would often be speaking on behalf of children, and clinicians weren't actually able to see the child's response. So we're very conscious that although digital technology offered a huge amount of support to us in terms of engagement, it was very limited in its use. So we're very much aware of being able to provide a safe environment to continue face-to-face contact with patients. So in addition to regular treatment plans that would be, I guess, reviewed and established for patients already in treatment, we used COVID care plans, COVID-19 care plans, and they were developed collaboratively with patients. And that the approach allowed us to be specific in terms of what care plan a patient already had in place, whether or not we knew somebody to be clinically extremely vulnerable, whether a patient was shielding, and what impact that would have in terms of the patient's care and treatment. And what to do, of course, if patients or family members develop symptoms. And often just those very conversations about knowing what to look for, knowing how to access help, knowing how to access testing was really, really quite important. The other thing that we did strive to do was to minimise the disruption on people's treatment plans. So additional things that we offered, we purchased some additional tablets that supported patients to access digital technology if they didn't have that themselves. So in April, towards the end of April, face-to-face contacts resumed. patients were asked specifically about their symptoms prior to their appointment, if it was a face-to-face contact. And again, that was part of an ongoing safety measure for both staff and patients. And in terms of our working environments, we've got very robust workplace risk assessments. They were carried out on each individual environment. Rooms were risk assessed to measure what the maximum occupancy could be in a particular room. We had some very, and still have, very strict use of PPE, and we make sure that hand washing or sanitising facilities are readily available when patients come to our environments. And just in terms of that continuation of safety, that's something that is ongoing and it continues to be monitored regularly. Could you go to the next slide, please? Thank you. I think there was a lot of uncertainty around the outset of COVID, and we weren't really sure how that was going to impact on our attendances. So people attending for routine appointments or people attending for new assessments, whether that be virtually, over the phone, or in person. But during the initial lockdown phases, what we saw was a minimal amount of DNAs or people who didn't attend. And on talking to patients about why they hadn't attended, it was very much related to anxieties about either coming into a hospital setting or environment, or concerns about mixing with others outside of their own immediate bubble. And patients, I think it's fair to say, were probably more reassured when the guidance around PPE became a lot more clear. Initially, there was also a decrease in referrals that were received into the community teams, and that was probably based on the fact that fewer people were accessing their own GPs for support, probably for the similar reasons that I'd outlined earlier in terms of patients coming to our environments. Over recent weeks, however, we started to see an increase in referrals, and we're certainly back to pre-COVID numbers. What we have seen is a number of patients who are now being referred to us from our inpatient wards, which probably indicates that there's an increase in the level of acuity before people are actually being seen either by the GPs or by our services. We've also noted that COVID-associated referrals are coming from patients experiencing anxiety regarding long COVID symptoms, and for people who've also worked in key roles throughout the pandemic. So people who've experienced trauma related to significant numbers of death, whether that's people working in care homes, for example, and people just generally being concerned and fearful for their own safety when they're working in high-risk infection situations. If you could go to the next slide, please. So in terms of what we've felt has gone well, we'll work through a plan to restart our memory services. I won't go through that in detail because you should have a copy of that paper in your packs for today. But in essence, it looked at ensuring that we had a more cohesive MDT approach, so multidisciplinary approach, and taking into account people's preferred communication methods, and using a combination of methods of care delivery within a safe environment. And that was driven specifically by choices made by either patients and their carers, and that's successful and it's ongoing, and it'll continue to be reviewed as well. So we use a very collaborative approach with care homes to access our patients and service user population who reside within care homes. One of the things that was a real game changer, I guess, is the lateral flow testing that we have, when we're able to offer people assurances that staff who go to care homes have carried out lateral flow tests at least twice weekly. So at any point there would be at least 48 hours earlier, they would have had a negative lateral flow test before going to see somebody at a care home. And I think that's really reduced the anxiety for care homes, but also for patients within care homes and their relatives. I mean, it must be incredibly difficult when relatives haven't been able to visit, and yet other people from outside, who are still part of a community, albeit they've got a job and a reason for visiting their own relatives. And it just goes to reduce the anxiety around transmission of infection. There were a number of anxieties, it's fair to say, in the use of digital technology initially, both amongst staff and patients, but I think as time's gone on, confidence has grown. And as we discussed earlier, although it's not a substitute for face-to-face appointments in all cases, there have been some really good examples of where it's gone well, it's worked well. We've had to be more creative in the way that we meet with our own teams and with partners to ensure that we haven't lost a sense of teamwork. And I think that was always a fear, that people would drift off and become quite isolated, and that in terms of how we're used to working historically, we're very used to having access to peer support as well as formal supervision structures. And if you take that away, it can be quite an isolating place to work. So we've done a lot to ensure that there's still a sense of teamwork. And in practice, we've staggered on-site working in COVID-secure environments, as I described earlier, and we use digital technology to ensure that people who are required to attend multidisciplinary team meetings and general team meetings are able to do so. And I guess just ensuring that we take time for our own staff to support each other and to be able to discuss their own anxieties. We've facilitated, certainly in the early days of COVID, daily check-ins with teams, and we've looked to increase supervision for staff utilising all disciplines. So, for example, we've got psychologists within our services who provide some wellbeing sessions for our own teams. And in terms of working with partners, we've always found a way to communicate virtually if we've needed to. And I'm sure if you ask most people now, it's probably second nature to think about contacting somebody either on Zoom or by Teams. And I think positively, it's reassuring that everybody that we've contacted have had the same kind of ethos about wanting to make it work, so we have found a way to make it work. Could we move on to the next slide, please? So in terms of our own workforce, I think it's fair to say that we're probably more flexible and adaptable. Certainly from our initial conversations about what COVID might mean and what the impact might be upon our workforce, we weren't certain what to expect at all. We weren't sure whether we would have a depleted workforce, whether we'd be able to actually continue to deliver our own core business. So we had to make sure that that and essential tasks were covered. So, for example, the day in the life of a CPN might have looked very different at the early outset of COVID to how it might have done historically. Thankfully, we didn't need to redeploy vast swathes of our workforce, but we did need to increase our patient contacts as other services around us stepped down. And more latterly, our workforce has been supporting our vaccination programmes. So we'll continue to utilise our staff in a variety of ways based on their skills. So there's a lot of work done around looking at skill sets and how that could be adapted to meet the needs during COVID. I think an important thing to talk about is staff resilience, so it's extremely important. We're starting to see signs of fatigue and burnout, and the levels of acuity of presentation and increase in referrals will continue to place pressure on what we see as an already tired workforce. So we'll continue regularly to take a sense check of how people are. We utilise our own occupational health supports when required. And we offer low-key supportive measures. So whether it's just time to have a cuppa and a cake through to more formal staff days, it's absolutely essential to continue to support our staff. Could we move on to the next slide, please? So this slide's really just a summary in bullet points of the areas of focus for us for the next 6 to 12 months. And I'm not going to go through it because I think we've probably done so earlier in the presentation, and I understand that you'll have an opportunity to hear later about the transformation agenda. I think that's at a later date. So I think at this point we're happy to take any questions. Thank you.
Thanks for that. Now I can't see everybody. That's better. Have we any questions for either Kath, Chloe or Pam? And I can't. Les, Councillor Bowman and Councillor Sesford. Councillor Bowman first.
Thank you very much, Chair. I was aware that in the community there was a lot of pressure because of COVID, and in my ward there was been a few incidents of self-harm, and I do recognise the challenges that we faced in the community regarding COVID and the stress that it placed on families and individuals. And I want to thank you for your hard work and your commitment, and you are providing a first-class service in many respects in challenging times, and And at the end of the day, I want to thank you for saving lives, because that's what you've done in the challenges that has been around us. Thank you very much.
Thanks for that, Councillor. Councillor Sesford.
Yeah, thanks very much, Chair. Yeah, a common theme throughout the speakers there was the fact that they need to be flexible and adaptable and meeting the needs that's been pushed on them by COVID. Now, we've obviously all done a fantastic job to adapt to the situations as it changed, or as it came to you, and then as it changed later on throughout the time. I was just wondering, basically, is there anything that's come about that you may think you may now use more often? So is there any techniques in that you've learned which you probably wouldn't have thought of before because you were never in this situation, but necessity being the mother of invention, you've had to adapt for this sort of thing? And I just wondered if every cloud has a silver lining, there's something that you've found that you can now use and adapt for your working practices going forward.
I'm sure there's a number of things. I mean, one of the things that we've seen just because of PPE is a reduction in infections. So for all we're seeing COVID infection, we're not seeing other infections. I mean, today's presentation has been very much around community services, but we're not seeing norovirus or flu. We're not seeing those kind of infections that we would normally need to work with. So there is definitely something about social distancing, wearing washing hands and wearing face masks that is a positive. Chloe, is there anything that you want to say? And then I'll go to Casa specifically, because I know your services addiction-wise have definitely made some changes.
Yeah, I mean, and I touched on it in the presentation. In terms of that virtual offer of group work, it's really hit a cohort of people that wouldn't necessarily have engaged in that type of treatment or therapy before. So going forward, we will reintroduce face-to-face group work, but we'll certainly have an offer of that digital going forward, just to ensure that we're able to capture that wider audience and people can certainly benefit from having the option of doing both.
Thank you very much. Thank you.
Excellent. Councillor Dungworth.
Thank you, Chair. It was really good to hear about the prompt response that the service made to the COVID crisis. And I think, you know, all our public services have responded exceptionally well under a great deal of stress. But I suppose I'm a bit concerned about where we go after this, because there are people, I am sure, in the community who have suffered a great deal of mental ill health during COVID, who are not known to the services, and because of the pandemic may well not have sought help, or indeed have other people who would encourage them to seek help. So I suppose it's the next stage really for picking those people up, where they were waiting lists for services, particularly for young people prior to the pandemic. There's no reason to believe that they're going to have disappeared. And yet I suspect there is an uncounted need out there at the moment. And I think I've raised before, one of the groups I feel most worried about are men and young men who will not have had the usual contacts with their mates, which might just have kept them okay, and are the least likely to seek help. So I suppose it's what next is my question.
I would say, you know, that's a really good question. So there are a couple of themes. Is we monitor all the time what the referrals are. So what we're seeing is, as Cass mentioned, is we're seeing more COVID related referrals, so people we possibly would never seen before who've been working in that environment. And the other thing that we're seeing is people who are attending for liaison psychiatry are iller than we would normally see. Mm-hmm. So people are waiting a lot longer to come forward. So I think one of the things definitely is to get the message out to come forward as soon as you need the contact. I would also say that we're seeing older adults differently than we would previously. So probably more self-harm within older adults as well. So I think we've all been quite focused on younger people and younger men who are always a high risk area. But I also think we've got things around older adults who have been so lonely I would say that the loneliness and the lack of contact with individuals is the biggest player that we've got at the moment. We look at all instances of self-harm or suicide. We're constantly looking to see what we can do differently within the community setting. Some of the things that we're looking to do is we've been really looking, we've got funding, extra funding for crisis services, and we've got more hopefully coming next year. And what we're investing in is that social contact together in a crisis, rather than and trying to get people engaged in communities rather than coming through for secondary services. Actually, we do as much as we can early on, because you're absolutely right. You know, the quicker we can support people, the better.
Can I just come back there, Chair?
Certainly.
That's certainly been my experience, both on a personal level and as a counsellor. It is about that loneliness, those older people who haven't had any of those normal services and are probably going to be some of the last to get back to them as well, ironically. But the other group that was highlighted this morning is young mothers and people suffering from postnatal depression. Now, I suffered from postnatal depression with both of my children, and one of the things that really helped was getting out, being with other mothers in a similar situation, having that support network. And of course, we've had children born in the middle of this who've had, and their mums who've had no contact really with any, not even with family members. So again, about, you know, my doctor's surgery did a fantastic thing of getting first-time mums together. And you know, they talk about teeth and breastfeeding and weaning and stuff, but actually it was about us getting dressed and getting our children dressed and leaving the house. That was the point of it. And it's those sort of community things that we desperately need to start up again to support those people.
Very good point, Susan.
Chair, can I come back and say that?
Yes, certainly, please do.
The more that we can do safely within a community setting, because I would say loneliness is the one for everybody. Do you know, if you narrowed it down, be it young men or older people, mums, it's definitely loneliness. So the more we can do to get third sector providers back out there doing what they were doing, it's really simple things, isn't it? It's that conversation, and it is great to see just on the TV and social media, that real push about just having a conversation with somebody and not a text. So that's a great way forward. Yeah,
I suppose obviously that leads to depression, loneliness, and drinking more alcohol, which obviously increases the depression. Yeah, good, very good point, Susan. I can't see any other hands up. Is there anybody else who wishes to ask any questions? No. I can't see anyone. I'd like to give my thanks to Pam, Kath and Chloe. Very interesting. And just to echo what Councillor Bowman said, our gratitude from everybody on the committee and from the council for all your work you're doing. And as Councillor Bowman said, for saving lives. So thank you very much. And hopefully we'll see you again in June.
Thanks very much. We'll see you in June. We'll leave if that's okay.
Yeah, by all means, yeah.
All right. Bye-bye. Take care, everybody. Bye-bye.
Thank you. Thanks.
Right. Going back to the previous item, Chris, have we anybody?
Yes, Chair. Jeremy Rushmer has joined from Northumbria.
Hello, I'm here.
Hi, Jeremy.
Sorry for being late.
It's okay. We've had one or two technical problems and one or two councillors have come in late. There's been a few hiccups today, so please just carry on.
So I've are we going to do? Am I going to share my screen? I can do that. Shall I do that?
Yeah,
that's my plan. I've never done it on Teams. So let's share that screen. Can you see that? Have I done that successfully?
Yeah.
And if I do that, then we go forward. Fantastic. Okay.
We all have copies of the report in our papers as well, just in case.
That's it. And you'll have heard a version of this from me over the last few years. So this is our quality account, which I'll just remind everyone is the look back over what's been a very interesting year. So looking back over 2021 and looking forward to our quality objectives for 21-22 for the next year. So this is just to remind you that we're in the middle of a 5-year strategy that the formal cycle ends in 2023, and this is our plan on a page. This hasn't changed from the last 2 occasions I've shown it to you, and to remind you that our vision remains to be the leader in providing high quality, safe and caring health and care services, and to lead collectively with partners to deliver system-wide health care. So it's just really to say that none of that has changed very much, despite this being an extremely interesting year. And so I'm going to follow up by going through this year's annual planning process and this year's quality account. So as I said, we're in a 5-year cycle that ends in 2023. This is the annual plan for 21-22. We do have a quality strategy, and it does include last year's quality account. That's a statutory requirement and will be published on NHS Choice's website, having gone to Parliament and to be consulted upon by all our normal stakeholders, of which this presentation is part, and we're hoping to seek your formal written feedback, which we'll include in the account. So the first part of the presentation is the 2021 quality account, and that's a look back at the safety and quality priorities for that year. It's a standard report for all trusts. The language that we need to use in that guidance is highly specified. There are certain key measures and phrases that we have to use that are auditable. It will include information on mortality and preventable deaths, as well as areas of achievement outside of our quality improvement targets. Due to COVID-19, there's been a small amount of change in the way this work is undertaken, so there is no external audit assurance work on the quality account, and so this will be presented without external audit opinion. And furthermore, no governor selected local indicator needs to be chosen for the year, so neither of those parts will be included. So the process is well underway. I've certainly seen our draft, and it will be ready for to be sent out to yourselves, we believe, in the next week or so, mid-April 2021. It will be circulated to stakeholders for their formal opinion around the end of this month, and then the timetable for your comments, the stakeholder comments, will be by the end of May 2021, with it being uploaded to NHS Choices by June 2021. The only bit that has changed is we don't have a date for submission to Parliament, and I think that's because they're still looking at how they'll make the timetable work because of the changes with COVID and the NHS bill. So just to remind you of what our, that we had 7 safety and quality priorities last year. Priority 1 was flow, looking at discharge. Priority 2 was the management of acutely unwell patients. Priority 3 was the supply and administration of medicines, particularly using patient group directions. Priority 4 was children and young people's emotional well-being and mental health. Priority 5 was end-of-life care and bereavement, and with the medical examiner's office. Priority 6 and 7 were patient and staff experience, respectively. So just to go back with what they were, so flow. The focus was on the back door, or the fitness for discharge and reducing length of stay so that people don't need to stay in longer than is medically necessary, making sure we've got the right amount of information to support that, and to note that we're now required to report bed occupancy as a national key performance indicator. Deteriorating patients and observations, we were improving the timeliness of observations and working on acute kidney injury, and also work on sepsis and antibiotics via a deteriorating patient board, trying to bring together a number of key strands of work into one location. Medicines management was the use of patient group directions and also the training of non-medical prescribers, particularly in community settings. In terms of mental health, our responsiveness to children and young people with emotional well-being and mental health difficulties, improving our CAMS pathways and reducing waiting times for access to specialist input and support. In terms of end-of-life care, consolidation of the bereavement and medical examiner work with the opening of the medical examiner offices occurring by the end of last year, ensuring that we learn through systematic clinical team review of cases, which we've done particularly usefully with COVID this year, and it's aligned to the end-of-life strategy work, which has been to a certain degree paused this year with the pandemic. Patient experience, we were looking at John's campaign supporting those with dementia who are inpatients and improving the management and assessment of pain for people with learning difficulties in the emergency department. In terms of staff experience, we continue to recognise the strong links between staff and patient experience. We found this incredibly useful this year with the Northumbria Voice real-time feedback from our staff, and we're sharing this approach with the NHS. So the next couple of slides are the summary tables for our performance against those performance indicators, and include as much up-to-date information for Q4 that ended a couple of days ago as we can manage. So we were on target for our flow, our discharge criteria. We managed to maintain our bed occupancy of less than 92%. This was greatly helped by a reduced influx of patients associated with the coronavirus pandemic, although our numbers really are at about 80% of where they were this time last year, so they're creeping back to normal levels, not all of which is necessarily a good thing. We've put in a place for capturing the information of declaring a patient medically fit, so that we can now manage the time between declaring them medically fit and discharge. And we have looked at reducing our length of stay for long stay patients, and we set ourselves a target of having less than 103 patients over 21 days or 3 weeks, which is our definition of long stay. That's in line with the national standards. And in Q4 has been our largest month as patients have been creeping back in, but we've kept that to 93. All the other quarters we kept very much lower. In terms of the management of acutely unwell patients, this is one of the ones where we felt we haven't really managed to progress this target. There's perhaps a number of reasons to that, not least the intensive work that you need to undertake with the quality improvement team in order to train the ward staff to focus on this as a priority, and we had to redeploy our nursing quality improvement team as part of our COVID response, where we deployed them to frontline areas. So we haven't deteriorated particularly through the year. We had set ourselves a target of 70%, and we've kept near to that, but we don't think we've managed to achieve that in the way that we wanted to. In terms of reducing the reliance on patient group directions. We have reduced the number of patient group directions, but more importantly, we've also reduced the area in which we actually prescribe from them, so that we no longer use these in any of our inpatient settings at all, and we'll continue to work on those. But we do need these in areas where we don't have sufficient prescribers, particularly our sexual health services in Northumberland and our urgent treatment centres. So we agreed to implement new pathways around children and young people's emotional health and well-being. We introduced an access team to manage our CAM service. We run a CAM service, particularly for patients at North Tyneside, and this has had a very positive impact on patient access to the service throughout the pandemic, and we're continuing to invest in that team through this year. We committed this year, in terms of end-of-life care, that the medical examiner would review 95% of all deaths that weren't referred to a coroner. Q4 so far, we've achieved that target of 96.9. We were lower in Q1 and Q2, but we needed to make some very significant changes to the way our medical examiner service ran, due to the changes in reporting arrangements and how death certification was undertaken, that were changed very quickly when the COVID-19 pandemic hit us. The stage 2 subspecialty reviews have been very successful, and we spent quite a lot of time, and we spent particularly quite a lot of time at the beginning of the year reviewing and learning from our experience in terms of COVID-19. This was particularly important to critical care and respiratory care, as it was a very fast moving field where there was quite a lot of change with the way that research was going, and with recruitment to the recovery trial. And I'm also pleased to report that Northumbria Healthcare was number 4 in terms of the recruiting organisations that weren't academic centres to the recovery trial, with all the benefits that brought with remdesivir, dexamethasone and tocilizumab, that are now standard treatments. So progress for indicator 6 in terms of John's campaign. We managed to complete the trial in August 2020 and disseminated the information trust-wide, but there has been a patient experience visiting project to understand the impact of that. Also, we were able to hold focus groups in between the first 2 waves around December 2020 to understand the experience of a focus group of patients with learning disability, and we've designed and formatted a health card which we will be implementing, although we won't be able to do that until this month, because it's taken longer due to the staff changes associated with COVID. Staff experience has been actually crucial for us this year. During the first wave, we had Corona Voice, which was a real-time staff feedback app and website that we piloted, which we later renamed Northumbria Voice so that we could keep it going. And it's been really interesting to be able to share the experience with staff, to focus our messages and support to areas that have been struggling, and to see how the pandemic has affected our staff overall. And I think we've come out all the better for this focus on staff experience, which has left us in a good place for recovery. All the domains of staff experience are statistically better from baseline. We've held workshops and we've done very, very well with the national staff survey again this year. So in terms of looking at our quality priorities for next year, that's year 21-22, So we have a process whereby we talk to our stakeholders, and this is part of this consultation. We've spoken to our business units, we've given feedback in board and our governors, and we've now identified 8 possible quality improvements. Some of these are priorities built on the previous improvement work. And it's really important to note that this is not a complete list of everything that we do. This is just really the ones that we put forward as our quality initiatives. There'll be an awful lot of work that we build into our annual plan that we won't be, that we undertake as part of our normal business. So, priority 1 is access standards. So what we really are very keen to do is to make sure we regain the access standards for patient access. So that's our 18-week target. That's working our way back through the waiting list to make sure we're completely caught up and fully recovered so that people don't have to wait. In outpatients, we want to make sure that we maintain a high level of patient experience, but also bring the benefits of the additional benefits of video consultation for those patients who want it, and to try and get the right balance between face-to-face and new audio-visual technology. In terms of priority 3, we'll be continuing to focus on the deteriorating patient, and we want to continue to improve the management of acutely unwell patients, both in hospitals and community settings. And I'm sure we'll be revisiting the timeliness of our observations and restarting the improvement work that we worked on with that. Priority 4, we set a target to improve the detection of patients with delirium and the training of staff so that they're able to spot the signs of delirium early on, so that we can act to try and both mitigate the consequences of delirium, but also treat the causes. We'll be continuing to work on reducing our need to rely on patient group directions, and continuing to improve how we supply and administer medicines to patients with and without PGDs. We're going to continue our work on child and adolescent mental health service. We recognise the impact that COVID has had upon young people in this service, and we want to make sure that we fully restore timely access to this important group. And we're retaining as 7 and 8 our patient and staff experience, with a focus on getting patient experience back to pre-COVID levels. And just today I was having conversations about how we can go into the remainder of this year with a new approach to getting visitors back into the organisation, so that we can support our patients, because that's absolutely vital to us. And of course, building on our successful staff experience. So that's all I was going to say in terms of the presentation. I'm going to stop sharing my screen, which I think
it's successful.
Yeah, I mean, you
Well
can now
done.
see me, and I've navigated presenting on Zoom for the first time. I've only done it before on Teams, and I'd be very, very happy to take any questions that you've got for me on that presentation or on anything else.
Thank you for that. It was very interesting. Have we any questions, please? Councillor Bowman.
Thank you very much for your presentation. I realise that COVID-19 has had an impact on the strategies, and obviously we have to be mindful of those who are suffering with long COVID. Have you taken that in account when you've done your strategy for the future?
So we we are dependent, I'm afraid, on the medical science moving with some of this. So I just need to point out that whilst long COVID is discussed, and I think it's definitely a very real thing at the moment, it means many different things to many people, and it will be patients who have severe respiratory, chronic respiratory illness as a result of their long stays in intensive care, all the way through to people who are suffering the post-viral effects. So we do have some support formally for long COVID patients. We are working with the CCG about extending that offer, but at least part of the problem that we need is we need some science and treatments to work out exactly what is the best way to treat these patients. But we currently run all our patients who have severe respiratory illnesses are followed up in a long COVID clinic, and we're taking referrals into that service, and we're currently looking at how we can support patients who have persistent physical symptoms from COVID as part of next year's strategy. But we're doing that joined up with the CCG and Newcastle.
Thanks for that. Is that okay, Councillor Bowman? Councillor Rickaby.
Thanks, Chair. Yeah, Jeremy, I was very interested in your training of non-medical prescribers, especially in community settings. I don't have a problem with that, but I think what I'm really seeking is how this will happen and how you are going to gain confidence of people that maybe have a blinkered view of how medicine should be prescribed. And I'm thinking, taking a slight tangent of those that have actually not wanted to have any COVID vaccination, if they then find that maybe if they are going to have some medication and it's not what they perceive to be the normal person that would give it, how you're going to get around it. Does that make sense?
Sort of. So there's a difference between prescribing medicines and administering them, which is something that's always much better handed over to my nursing colleagues, even though I do occasionally give them myself. So we are entering what I could describe nationally as a bit of a prescribing crisis. So I think this is something that all trusts are finding themselves in, because the prescription of medicines is something that has been largely done by doctors, and the doctors are now being used much more for the assessment of patients. And so this is part of our workforce problem, and something that we feel particularly acutely in our community settings. And so, for instance, if you think about the arrangements at Berwick Hospital, how we arrange for someone to get antibiotics after 8 o'clock at night when the GP out of hours service is run from a warehouse somewhere in Gateshead now, this is causing real difficulty. So actually, by creating nurse and non-medical prescribers, we're improving the access to new medicines for patients, so that people don't have to travel in order to have those prescriptions made, and to be able to make the use of electronic prescribing. There isn't a magic formula to this, though. There is a prescribing course, and it is quite hard work to get through. It takes most people about 2 years to undertake that. And there is only a limited amount of spaces available, which we're trying to get Northumbria University to increase. So we take up all of our allocated slots and more. And this is what we're using to try and keep all of our urgent treatment centres and our wards in community settings open. The vaccine has always been given by patient group directive. So even when I was working in the vaccine hub, I didn't prescribe any of the vaccines except to one person who fell out of the wasn't within the guidelines of the patient group directive. All of our vaccinations, all the way through school vaccines, through COVID vaccines, flu vaccines, they're all done by PGD, and that's what allows a few questions to be asked, and whether they're a doctor or a prescriber or a nurse, results. And if you answer those questions and meet the criteria of the PGD, you're just given it. It's a pure efficiency thing. So I hope everyone has confidence that patient group directives used in the right way are extremely beneficial, and they'll be carrying on for vaccination. But there are some circumstances where the changes in the clinical workforce mean that in order not to move patients to prescribers, we need to increase the availability of prescribers. It's really a service that we're trying to provide to keep our community services going longer.
That's great. I mean, there was certainly no criticism to say I'm all for any ways or means that can actually make the service better or function smoother. And I think, as I say, it's just getting people's mindset changed, that there are other ways and means that you can deliver something without going through what we perceive to be the norm. So thanks for that, Jeremy.
So just to say, I mean, I'm always supported by a pharmacist prescriber during my ITU wardens, and I absolutely promise you they do a much better job at prescribing the drugs than I do. As doctors, we're very distracted. They're now in complicated electronic systems, and there are people who, when properly trained, do a fantastic job at this.
Great, thank you.
Thanks, Lizzie. Councillor Dungworth.
Thank you, Chair. I just wondered, in light of particularly the report on discharge of patients and the work done around that, I'm just interested to try and get some understanding of why the Trust has decided to dissolve the partnership between the County Council and the Hospital Trust, because I always thought that actually set us out as being quite special.
So Ross, my comms colleague, will be extremely concerned that you're asking a question above my pay grade. So there are some technical and governance reasons that we've wanted to look at the partnership, but it is quite possible from a clinician perspective that we've been working in a number of different environments, both in Northumberland and in North Tyneside, where I think you'll understand that the arrangements do differ slightly. That actually, from a clinician's point of view, it doesn't matter who you're employed by. That's not the key question, except in terms of around where your payroll comes from. It's really the key question for making discharge safe is about how the staff involved in the process work together, and we remain 100% committed to integrated care. And I think it is possible, if there were some governance issues that we wanted to resolve and bring clarity on, that we could be in a much better circumstance, having reviewed the working arrangements and got sort of clarity moving forward. So I can't answer your question specifically around discharge, except to say we remain completely committed to the clinical care and the safe discharge of our patients in a timely fashion.
Seems quite an unusual move when nationally the move is towards closer partnership working between local authorities and the health service, that we seem to be going in the opposite direction. And I just really don't understand why, nobody's explained to me why that is. So I think at some point, Chair, it would be quite useful for this scrutiny body to try and understand that decision and the implications of it, please.
Yeah, I'm sure we could add that to the work programme, Councillor. I totally agree. Yeah, we can see about doing that in the next council year, certainly. Any more questions for Jeremy? I can't see any hands up, so I'd like to thank you very much for your presentation, and struggling on with the technical side, but you did very well to get that through. Thank you.
There's just,
once
Chair,
again.
there's just one final thing I could say. I just really wanted to thank everybody for their help through the last year. It's been something we've all shared together. I live and work in the community, and we couldn't have managed to get to where we are after this third wave without the close working relationships we've not only had with colleagues in the council and health and scrutiny committee, but also the way the public have responded to this joint problem that we've all been in. So it's just really to record my thanks for that.
Yeah, I was just about to do the same to you from this committee and from all of the council, for all of the staff for all the fantastic work they've done in this very, very strange year. Hopefully in the very near future we might start to get back to some sort of normality, but thank you once again for your presentation and all the work you and your staff have done over the last year or so.
Okay.
Thanks kindly.
Thank you. I'm going to leave you now.
Yep, thank you kindly.
Hope you have a nice afternoon.
And
Thank
same to you.
Thank you.
Thanks for that. Right, item agenda number 8, which is work programme. Chris, I think it's just to note.
It is at this point, the work programme's just to note for members, and we'll start to plan the work programme for the next council year as soon as we can.
Thanks for that, Chris. Any urgent business? I don't have any. Chris, again, you were just on there. Any urgent business that's come through?
Not that I've been told of.
Right. Thank you, Chris. You will see on your agenda papers that the date of the next meeting was the 4th of May. There won't be a meeting on the 4th of May. I think that was put in case there wasn't an election with the COVID. So this will be the last meeting of this council year or period. Firstly, I would like to thank, I've only been chairing this for 6 months or so, but I've thoroughly enjoyed it. It's been unbelievably interesting and very informative. I'd like to thank you all for your participation. Every meeting you've always come up with some really good questions, and you've been very, very supportive on that. And I'd especially like to thank the Vice Chair Leslie, which has been a great Vice Chair and very supportive. And really thanks to Chris and Kath, who Chris does all the hard work with Kath behind the scenes, and Leslie, to make sure that these meetings go ahead. So they do all the hard work. So thanks very much to them. And all I can do is wish everybody the best on the 6th of May. Good luck on that to everybody on all parties. And we hopefully will see you all after the election. So thank you very much for your participation. Thanks now.
John, could I just say my apologies for coming in late. I just couldn't get online, so I'm in now.